In this video, we will discuss Orbit score. This score can be used to predict bleeding risk in patients with atrial fibrillation. First, let's briefly go through the study which was used to develop this score. O'Brien et al. In 2015 used data from Orbit AF registry to develop both a full continuous predictive model and a simple bleeding risk score to help predict bleeding risk in atrial fibrillation patients on anticoagulation. The five most predictive bleeding risk scores, which were weighted depending upon their strength of association with major bleeding, were included in this bleeding risk score. The study populations from Orbit AF registry and Rocket AF trial were used to compare predictive performance of Orbit score with other two existing bleeding risk scores, that is HAS-BLED and ATRIA score. And these studies showed better predictive ability of Orbit score compared to HAS-BLED and ATRIA score in predicting bleeding risk in atrial fibrillation patients. After briefly going through the study which was used to develop this score, let's go through the algorithm of the Orbit score. There are a total of 5 criteria which are included in this score. The letter O stands for older age, the age 75 years and above. The letter R stands for reduced hemoglobin or reduced hematocrit level, with hemoglobin level less than 13 gram per deciliter in males and less than 12 gram per deciliter in females. Hematocrit level less than 40% in males and less than 36% in females. The letter B stands for history of bleeding. The letter I stands for insufficient renal function with eGFR less than 60. The letter T stands for treatment with antiplatelet agents. The criteria of older age, insufficient renal function, and treatment with antiplatelet agents are allotted 1 point each, while the criteria of reduced hemoglobin or hematocrit level and history of bleeding are allotted with 2 points each. Thus, the maximum score that can be allotted to a patient is 7. Now, let's see how to interpret the Orbit score. With increasing Orbit score, the risk of bleeds per 100 patient years increases and thus the risk category of the patient. The Orbit score between 0 to 2 classifies patients in low risk category with average bleeds per 100 patient years being 2.4. The Orbit score of 3 classifies patients in medium risk category with average number of bleeds per 100 patient years being 4.7. While the Orbit score of 4 and above 4 classifies patients in high risk category with the risk of bleeds per 100 patient years being 8.1. Now let's go through the studies which compared Orbit score with the other risk scores. The study by Predictive et al. Which compared contemporary clinical bleeding risk scores in atrial fibrillation patients of the Relay trial showed that the Orbit score had the best discrimination and calibration among all contemporary clinical bleeding risk scores. While the study by Pastor et al. Which compared HAS-BLED score with Orbit score showed that there was no clinically significant difference in predicting major bleeding and death in real-world anticoagulated AF patients. Similarly, a systemic review and meta-analysis by Wang et al. Demonstrated the underperformance of Orbit score in predicting bleeding risk in AF patients and thus showed that compared to the HAS-BLED score, the Orbit score does not perform better in predicting major bleeding events in anticoagulated AF patients. The studies by Sinoke et al. And Rivera et al. Showed the better predictive performance of HAS-BLED score over the Orbit score. Rivera et al. In addition showed that adding labile INR to Orbit score can improve its predictive value for major bleeding. Further, the study which compared Garfield AF score with other bleeding risk scores demonstrated the superior performance of Garfield AF score over all other bleeding risk scores including Orbit score. Gao et al. Which compared European risk scores with other bleeding risk scores showed the similar predictive value of Orbit score and the European risk score. Then the analysis of various bleeding risk scores in patients with atrial fibrillation by Chang et al. Demonstrated high specificity of Orbit score in predicting clinically relevant bleeding. Now let's go through the studies which compared Orbit score with stroke and other bleeding risk scores in AF patients receiving NOACs therapy. All these studies demonstrated modest but similar performance of all the risk scores in predicting NOAC-associated bleeding. The Leb et al. Showed the better performance of Orbit score with the threshold between 2 to 6%. Now let's go through the study by Shenjai et al. Which correlated the Orbit, HAS-BLED and TIMI score with 30 days mortality in STEMI patients. This study showed that the orbit score above 3 points was associated with the increased risk of death at 30 days. Thus, the high orbit score is an independent predictor of 30 days mortality in STEMI patients. In addition, the predictive values of the TIMI and orbit score did not differ significantly, with the exception that the TIMI score is more sensitive. Further, the TIMI and orbit score were significantly superior to the has-BLED score in predicting 30 days mortality in STEMI patients. Now let's go through the advantages and disadvantages of the orbit score. The advantages of the orbit score are that it is simple and easy to remember. In addition, the study population which was used to develop this score included the patients who received both vitamin K antagonists as well as DOAC therapy. This is in contrast to the has-BLED score, which was developed from a study population on vitamin K antagonists only. Thus, though orbit score is not superior to has-BLED score, it is more recent risk score compared to the has-BLED score and has been validated in the era of DOAC therapy, thus it may be more useful. Now let's go through the disadvantages of this score. In contrast to the has-BLED score, the orbit score does not consider the time in therapeutic range. Similarly, unlike the Garfield AF score, the orbit score does not consider the choice of anticoagulants. In addition, the risk factors which are not included in the orbit score may influence the decision of clinicians regarding anticoagulation treatment in the atrial fibrillation patients. So to conclude, instead of or in combination with other bleeding risk scores, it can be used to determine the risk of major bleeding and thus can help guide the decision to start anticoagulation therapy in patients with atrial fibrillation. In addition, in case of patients who are already receiving anticoagulant therapy, it can be used to guide the treatment modifications. So these are the references you can go through for further details about orbit score.